Dear colleagues, welcome to this lecture. Today we focus on botulinum toxin treatment of the forehead. Our structure will cover anatomy, aim of treatment, patient selection, injection technique, dosage, complications, and clinical pearls. This is not a superficial overview, but a true course-style training. By following this series, you will gradually complete a full curriculum on botulinum toxin applications. And as always, a reminder, this content is for educational purposes only. Clinical practice must be based on product labeling, patient consent, and your professional judgment. Applied anatomy and practice. The primary muscle we target in the forehead is the frontalis muscle. It originates from the galea aponeurotica and inserts into the skin of the eyebrows and forehead. When it contracts, it lifts the brows and produces horizontal forehead lines. Its antagonists are the corrugator, procerus, and depressor supercilii. But what really matters is not only textbook anatomy, but applied, functional anatomy. Place the patient in front of you and ask them to raise their eyebrows. This allows you to observe the borders and functional strength of the frontalis. The superior border ends roughly where the hairline begins. The lateral extension varies between individuals. By observing expressions, you can also detect asymmetries in muscle contraction. After observing, you mark your points when the muscle is at rest, having already identified its borders during movement. A fundamental principle: we do not inject the wrinkle itself, but the muscle that generates the wrinkle. Wrinkles are the symptom, the muscle is the cause. Mapping the active areas of the frontalis ensures both safety and precision, the goal of treatment. Our goal is not to paralyze the muscle completely, but to reduce its activity. If you abolish all movement, the patient will look expressionless. If you simply reduce movement, the patient retains natural expression while preventing the formation of new lines. For patients who receive botulinum toxin regularly, the frontalis remains weakened for around 6 months. A muscle that is not used becomes thinner rather than stronger. Instead of producing deeper wrinkles, it stays relaxed. In this sense, you are slowing down the clock of aging. And who doesn't want to slow aging? With longer lifespans and greater social awareness, this treatment has spread far beyond celebrities and the wealthy. Today, many ordinary patients choose botulinum toxin as a priority for maintaining a youthful and fresh appearance. Patient selection and documentation. We distinguish between 2 types of wrinkles. Dynamic wrinkles appear when the patient raises their brows. Static wrinkles are visible even at rest. The best results occur with dynamic wrinkles, but static lines can also be softened over time with repeated treatments. Always document patients with standardized photos and videos. This is not optional, it is part of the procedure. Patients forget their baseline appearance quickly and may compare themselves to friends or influencers. Having visual records allows you to show them the real improvement and protects your credibility. Be especially careful with patients who already have brow ptosis or heavy eyelids. In such cases, injections must be more conservative to avoid worsening drooping. From a professional perspective, think also about building a loyal patient base. A simple calculation. Imagine you start with 20 patients in the first month. 6 months later, those same 20 return. If each month you add another 20 new patients, by the end of the year, you will have a strong rotation and a stable practice. Technical skill plus trust and relationship building equals sustainable growth. The 3-band rule. The most important technical principle is to divide the frontalis horizontally into 3 bands: upper, middle, and lower. Lower band, this is the portion closest to the brows. Never inject here. Weakening this band removes brow support and can cause brow ptosis. Middle and upper bands, these are the safe and effective zones. Here we achieve smoothing of forehead lines without compromising brow position. The standard injection plan uses 5 points, 1 central, and 2 on each side. All points should be in a straight, symmetrical line. In men, aim for a flat, horizontal line for a natural masculine look. In women, place the lateral point slightly higher toward the hairline, creating a subtle wide V shape. This gently elevates the brow tail and gives a refreshed appearance, similar to the effect of a tight ponytail or a mild brow lift. Be cautious not to exaggerate the V. An overly sharp arch creates the Mephisto sign, giving a sinister expression. If this happens, it can be corrected at follow-up with small balancing doses, but prevention is always better. Also, you may see that different practitioners use different mapping patterns. Do not let this confuse you. The true goal is always the same: to deliver the botulinum toxin into the correct muscle, in the correct dose, with precision. Dosage made simple. Reference guidelines suggest Botox 10 to 15 units in total, Dysport 25 to 40 units in total. Practical Dysport math: diluted with 2.5 milliliters saline, 0.05 milliliters equals 10 units. 0.025 milliliters equals 5 units. Minimal approach: 5 units at each of 5 points equals 25 units total. Recommended distributions: central, 5 units. Next points, 10 units each. Outer points, 5 to 10 units each. One example pattern is equals 45 units. For younger patients with mild lines, 25 to 35 units is usually sufficient. For Botox, distribute 10 to 15 units total across the same 5 points. This unit math may seem confusing for beginners. A practical trick: think in halves and quarters. For Dysport, 0.05 milliliters equals 10 units. Half of that is 5 units. In practice, a half or a quarter can help you calculate quickly without constant reference to numbers. Complications and their prevention. Brow ptosis, the most common complication caused by injecting into the lower band. Prevent it by strictly following the 3-band rule. Mephisto sign, the result of lateral points being too superior or too strong. Prevent with balanced placement. If it occurs, correct at follow-up with microdoses. Residual wrinkles. Sometimes fine lines remain at the upper forehead. In that case, minimal touch-up injections can be added later. My personal observation: with the doses mentioned here, residual wrinkles are rare. Correct marking and balanced dosing are usually sufficient. Practical pearls: identify the muscle borders while the patient is making expressions. Then mark your injection points when the muscle is relaxed. Remember, inject the muscle, not the wrinkle. Do not inject into the lower band. This is the red zone. Take photos and videos of every patient. Even if you never share them, they are essential records. Patients often forget their starting point and may underestimate the effect. Visual documentation proves the value of your treatment. Schedule a follow-up at 1 to 2 weeks. Make corrections if needed. Aim for reduction, not elimination of movement. Natural results make patients more satisfied and more loyal. And finally, think long-term. Every treatment is not only about lines, but also about trust. A stable patient base is built with reliable technical results and strong human connection. Closing. In this lecture, we covered the forehead in depth: applied anatomy, treatment goals, patient selection, the 3-band rule, mapping, unit calculations for Botox and Dysport, possible complications and how to prevent them, and practical pearls for daily practice. This series is structured as a complete course. In the next lecture, we will move on to the glabella. I hope everything was clear. Did you fully understand it? Do you have any questions or points you would like clarified? If you found this content valuable, please like the video, subscribe to the channel, and turn on notifications. Share your thoughts in the comments and connect with us through the social media links in the description. See you in the next lecture.